Hello, everyone, and welcome to my presentation for the 2021 Research and Creative Achievement Conference. My name is Brandon Matthews. I'm a graduate student in the Master of Science in Athletic Training program here at Merrimack College, and my case study is about the surgical and rehabilitative outcomes of the Latarjet procedure in a patient with chronic shoulder instability. So to start off a bit about the patient, he was a 20-year-old competitive collegiate fencing athlete that I was introduced to in my most recent clinical rotation at Boston College, and he presented with a history of chronic shoulder instability. His initial chief complaint was right shoulder pain that happened several weeks prior after his mechanism of injury, and after the initial and follow-up evaluations, along with different diagnostic imaging such as x-rays and contrast MRI, the patient was diagnosed with a glenohumeral labrum tear secondary to an anterior dislocation of the shoulder. So with the significant bony loss involved with the injury, the patient was not recommended for the standard Bankart repair to repair the labrum, as this was a procedure he previously underwent back in high school during his senior year playing goalie for the soccer team. Instead, this time he was recommended to undergo the Latarjet procedure in order to further restore stability to the joint. So just a bit about the Latarjet procedure itself. The principle of it is to cut and reposition part of the bone, which is the coracoid process, and the short head of the biceps tendon in order to correct that bony defect and inhibit that humeral head from dislocating anteriorly. So if you look at that picture to the left, you can see the coracoid process being cut and the transposition of that tendon along with it. And with that, they also make a small incision within the subscapularis muscle and then reposition the coracoid process in a new position to kind of act as a bony block and to prevent that anterior dislocation from happening. So the purpose of this case report was to outline the success of this Latarjet procedure in this patient that had recurrent shoulder dislocations and chronic instability, and also to outline safe and effective rehab methods for those recovering from this procedure. So just a bit about the rehabilitation timeline and the different goals that were set at each stage. When I first met this patient, he was towards the end of phase 1, around the 5 or 6 week mark, and he had been working on goals such as just protecting the post-surgical shoulder, trying to activate those glenohumeral and scapulothoracic muscles, and to begin limited active and passive range of motion exercises. And so when I first started working with him, we definitely worked on developing some short-term and long-term goals that were varied throughout each phase of the rehabilitation process. So one big thing in the beginning of this process was just having those increases in glenohumeral range of motion. Moving towards the middle stages, he worked on incorporating increasing amounts of proprioceptive and dynamic neuromuscular control exercises. And towards the end, he's really been trying to gain confidence with different sport-specific movement patterns that are used in the sport of fencing. His long-term goals, on the other hand, included becoming more independent with ADLs, or activities of daily living, after relying on others for significant time after his surgical repair. And then along with that, just returning to play and being able to compete at a high level for his final 2 collegiate seasons. So throughout this 4-month clinical rotation, I've seen the patient approximately 2 to 3 times for a treatment session each week, working with myself and the certified athletic trainer, individual sessions with the physical therapist, and also limited work with the strength and conditioning specialist as much as he could perform. This was also helpful in getting him to be involved with the team and also have that camaraderie for the rest of the year, although he wasn't able to participate. So looking a little bit at the initial post-surgical intervention, as I talked about before, I had to focus on protecting that surgical repair, and that involved frequent cryotherapy, such as game-ready or ice massage, to help decrease that pain and inflammation the patient was experiencing. And also patient education was huge, just about the use of a sling for immobilization, and we use that as kind of a focal point to really protect that repair in the beginning stages. Looking at the intermediate stages of rehabilitation, we focused on progressing from passive first, moving on to active assisted, and finally to active range of motion exercises in hopes of gaining back that full range of motion within all planes in both the glenohumeral and scapulothoracic joints. One thing in the intermediate stage that was also used were different joint mobilizations, specifically grades 1 and 2, to help with that pain and spasm that he was experiencing. And we also started working with different isometric and light isotonic strengthening exercises that were beginning to be introduced through the patient's available range of motion at that time. And then just the final stages of rehabilitation really emphasized further progression in that strengthening and the introduction of more proprioceptive and sport-specific exercises to really help increase that neuromuscular control and glenohumeral mobility. And there was an focus on really increasing that core strength and mobility to help decrease the chances of any compensatory movement patterns within the shoulder from developing. So just here we have a few of the exercises that were key throughout his rehab that we really progressed each day, such as banded exercises working with external internal rotation, different rows and pullbacks, and also D1 and D2 flexion and extension patterns, which were huge in gaining back that range of motion in the beginning stages when he was progressing from passive to active assisted, finally to active range of motion. All of the interventions provided over this time definitely followed a stated protocol that was well aligned with the healing process of the repair tissues. One key focus of this rehab process was increasing the external rotation range of motion, as well as subscapularis strength. From past clinical research, it was learned that the immobilization period has been shown to impact the subscapularis in terms of its length and force production ability, as well as also impacting the external rotation range of motion due to the newly introduced bony alignment. And this has recently been seen in other clinical research. So that was definitely a big focus of this process, increasing that internal rotation strength and really getting that external rotation back to where it needed to be when comparing bilaterally. The patient's short and long-term goals have been continually met throughout this rehab process, as he has been very diligent and actively engaged with his treatment sessions each day. And a major goal towards the end of the rehab process has been mentally preparing the athlete through his different sport-specific simulations, as his injury history and chronic instability has created a mental hurdle for him to overcome in order to confidently perform at that high level he needs to. So currently, this athlete is beginning to approach the end of his final stages of rehabilitation and is steadily improving each day. Both myself and the athletic trainer I am working with believe that having the opportunity to continue to work on this rehabilitative exercise plan and treatment plan throughout the rest of the year and into the summer off season will help to properly prepare him both mentally and physically in his eventual return to play next season. Once again, having the athlete who was committed and driven throughout the entire rehab process allowed him to progress nicely from each stage, and he did not experience any setbacks throughout the entire rehab process. And finally, future research comparing different outcomes between this unique athlete population of fencers versus athletes with a more overhead movement, such as baseball pitchers or volleyball players or football quarterbacks, might be valuable in helping to create a more patient-centered treatment plan. Finally, I would just like to acknowledge the Boston College Sports Medicine Department, the overseeing certified athletic trainer, and the individual athlete themselves for allowing me the chance to assist in patient management and rehabilitation, and also for the inspiration for this case report. Thank you all for listening. Hope you enjoyed.